A very warm welcome to our hospital. I'm Sherwood McCaskey. As always, I'm pleased that you have joined us. This week we step back to our last episode and begin this time around with Nakisha Scanterbury, a registered nurse and midwife, as she prepares the ladies for delivery.
Let me give you a scenario. So a patient comes in for cervical ripening, what we call cervical ripening IOL, and let's say that that patient is a diabetic patient. So you come in and you know that you're coming in for delivery. During that process of admission, we inform you why you're here, or even we ask you why you're here so that we can know why you have come. What you don't remember, we fill in. So you've come to go to labor ward. You've come, this is what I expect. You're not in labor as yet. What we will do is make your cervix ready for delivery, what we will call cervical ripening. We use something called a urethral catheter, and that goes into the cervix and causes the cervix to dilate, what we call ripening. And once you're about 3 centimeters dilated, then you'll be transferred, what we call the induction of labor, as you would have heard me call it, IOL, induction of labor. And that, yes, I should have explained that earlier, induction of labor. So when you come over to the labor ward, then we give you artificial oxytocin. That's a normal hormone that is already in our body for if persons like me go into labor naturally, my body will normally produce that, but because you're coming for induction of labor, we are giving it to you to initiate those contractions. And then for some patients, you can give it, and then you do the rest on your own. So when you come over here, is monitoring. You are given medication artificially, intravenously, so which means that we have to be monitoring you all the time. If you were doing it on your own, then we can do what we call intermittent auscultation or intermittent monitoring, because it's a normal process. But once you come from over the antenatal aspect to labor ward as the induction of labor, you will be monitored constantly.
Patricia Watson-McCollin is the nursing officer of the labor ward here at our hospital. In explaining her duties, she assures you that expectant mothers and their newborns can be certain of the best possible care here in the labor ward.
So as the supervisor here on labor ward, I facilitate ensuring that adequate staffing on duty, ensuring that I allocate the staff adequately as well. And when we are short-staffed, I, as the supervisor, have to step in. I haven't forgotten my midwifery skills, because I often have to use that here on labor ward. I really do love my job, and I put my all into what I do. There are often times that I will stay back on duty to ensure that my staff, they're okay. Especially if I know that there is going to be a difficult delivery happening, I will stay and make sure that all is well, even if I'm just there to make a call to ensure that things are in place. I will do that for my staff and the woman who is in labor. If there is a difficult delivery as the supervisor, or they will consider me to be a senior midwife, and I have some person junior on duty, I am the person that will step in and take over that delivery. Yes, if we have a case of a shoulder dystocia, I will step in as the senior midwife on duty and take over that delivery. Yes, we will call all the other health professionals on duty, which will be the obstetricians, the pediatricians, but as the senior person on duty, I am that person that will step in and take responsibility. All right, shoulder dystocia is one of our major obstetric emergencies. So in that case, we would have to, like I said, involve all the other professionals on the team, which will be obstetricians, the pediatricians, and we would have to do various maneuvers in order to have a safe delivery.
Essentially, you are in safe hands here at our hospital and can expect the best possible patient care while in the labor ward. Patricia Watson-McCollin continues to detail the work of the ward.
Right. Labor Ward is responsible for all the deliveries here on island. We also see most emergency cases. Let's say there was a pregnant lady who came in who was ill regarding one of the minor disorders in pregnancy, whether she was vomiting, she's having abdominal pain. She'll be, once she's above 20 weeks gestation, she goes through accident emergency and she comes to Labor Ward to be seen. We have an admissions area. It's a 3-bedded area where we see those cases. If she is not in labor, she can be seen by the doctor, and then she would either be admitted to ward B2, B3, or she would be discharged home. If she is in labor, or if she has another issue, let's say she needs to stay in hospital, she would be seen by the doctor, and then she's admitted to the antenatal postnatal ward, which is ward B3, B2. If she is in labor, she's under the care then of the midwife, and we transfer her then to one of our delivery suites. We have 5 delivery suites, and she's then monitored by the midwife until she delivers. Midwife stands for with woman. We are with the woman while she is in the laboring process, as well as in the antenatal period and postnatal period. We are the persons who would liaison with the other healthcare professionals. Believe it or not, we as midwives do majority of the deliveries here in Barbados. The doctors only get involved if there is an emergency, but we are the ones who do the deliveries.
So on Labor Ward, the midwives are not only present to assess the lady throughout the laboring process, are, as you know, a midwife means being with women, but midwives deliver the baby. And this dates back from years and years ago, you know, when midwives were with women, etc., etc. If there is a complication, then a doctor will be summoned. If a patient comes that what we will call large for gestational age, their baby is large for gestational age, and you usually have ranges of what is expected, and if it's above that, then you can have a doctor present. If the baby's heart rate is low, if the mother's blood pressure is high, so they got different things that can happen outside of a normal delivery, and it is at those times that you will call and ask for a doctor to be present or a doctor to take over. But during the delivery time, normally it is the midwife who is present.
Well, labor is a process. It's something that just doesn't happen as we see it on television. We go from 0 to 10, and that's 0 centimeters to 10 centimeters dilated, and it's a process. It takes a time. So while that is happening, we monitor this lady until she delivers. We have to monitor you every half an hour, where we do your blood pressure, we do your pulse rate. We also check the baby's heart rate to ensure that all is well. Because just imagine, baby is being squeezed with those contractions, along with mommy going through the pain of the contraction. So we have to monitor them both closely. So you go from 0 to 10, and with in that time period, we do checks as well, where we do a vaginal examination every 4 hours to see if you are dilating, if your cervix is actually dilating, meaning opening, because the cervix has to go until 10 centimeters so that the baby can come through the passage. All right, so that takes time. So once that happens, then once you're fully dilated, then we can encourage the lady to go ahead and push until she delivers, which will be from first stage to second stage until third stage. The time of delivery depends on each woman. Each woman is different, so you have to treat the person holistically. On average, you can dilate from up to 1 centimeter an hour. A first-time mommy may take longer than a lady who would have had a baby before. So time period depends on each individual. From 0 to fully dilated, it would be first stage. Second stage is from delivery of the baby until the placenta and the membranes are delivered. Third stage, obviously, then placenta and the membranes are delivered.
Skin-to-skin contact provides a multitude of benefits for newborn babies. ranging from physical health advantages to emotional well-being. It is a simple yet powerful practice that not only supports the babe's immediate needs, but also lays the foundation for a strong parent-child relationship and healthy development in the long term. Nakisha Scanterbury speaks of what happens immediately after delivery.
Once it's a normal delivery, the baby is delivered, baby is placed on the mother for an hour to do skin-to-skin contact. So that helps with the normal adaptation of the baby into our environment. It kind of reminds baby, yes, I'm still with this lady. Yes, I can still feel her heartbeat. Yes, I can still feel that warmth. Yes, I can breathe normal. Yes, my blood sugar don't have to rise, Yes, I can start to root and look for the breast that I can breastfeed. So that is one of the first things we do after a normal delivery. Then after that, baby is taken to receive what we call routine care, receive vitamin K injection or erythromycin eye drops or eye ointment, whichever is provided, and then dressed or returned to the mother and dressed in her presence. After a safe delivery, the patients are taken to ward B3. B3 is our postnatal ward. Here we host patients that are receiving care or routine care until their departure from the hospital. So once the mother and her baby are transferred, obviously assessments continue because you don't want any complications to arise, but it is to watch the mother and the baby come together and adapt the mother's responses, whether she's engaging, she's feeding the baby, she is looking at the baby, whether she's admiring, showing that affection, whether the baby is responding, sleeping, passing urine, looking to feed. We assess, and then I shouldn't say and then, along with assessing, teaching, to let the mother know what her role is. And for me personally, I like to say, well, you have a new person in your life. Now is the time for you to get to know this new person. This person cannot talk, but you can observe and watch the behaviors, and then you can see, well, what baby likes, what baby don't like. Research have shown baby cries for different reasons. Now it's time for you to learn why your baby is crying, whether I'm hungry, whether I'm hot, whether my nappy wants changing, and go from there. Okay, once the patients are discharged, someone usually comes to collect the patient. Whether it's their significant other or a relative or friend who is responsible, will come to the ward and escort the patient downstairs. And there they will leave in a vehicle to go home. There have been situations though where persons had to work and the patients are discharged. But once they have money, what we do, we call the hospital taxi, and the taxi man or woman usually comes up to the ward, receive the patient, and take them to their respective places. So we do provide aftercare, but it depends on the type of delivery. It depends on the maternal conditions, and you would have mentioned something like diabetes, but they can put in there also hypertension. It depends on babies, if baby is of the normal weight or low birth weight. So yes, our patients do come back. So you can say, for example, if the route of delivery was a cesarean section, instead of visiting your private doctor or your polyclinic, you will be returning to our postnatal clinic. So it's no longer antenatal clinic, but be a postnatal clinic for you, for your follow-up assessment at 6 weeks. And once all is well, then you will not have to visit us again. If it is that you are having challenges with your blood pressure, you will come back to us here at the hospital, and we will do blood pressure checks until they are deemed normal or you are deemed fit for discharge. the baby as well, if it is with regards to the baby and their need, their weight check, or something else done, they return to us here at Ward B3 and someone will see you.
Best practices are essential in a labor ward to promote maternal and neonatal safety, reduce complications, and improve overall outcomes. By adhering to evidence-based guidelines and fostering a culture of continuous improvement, labor wards can provide high-quality care and support to women during childbirth, contributing to healthier and more positive birthing experiences. What are some of the best practices that you may consider?
I love that you come with expectations and not knowing. I think that if you're going through a season in life where it's a change of life, and pregnancy really is a change of life, not only for you, but for those who are involved and those who you will be coming into contact with, have a little knowledge. So if you're going to become pregnant, or even if it happens unplanned, because a lot of pregnancies do happen unplanned, have an idea. My body is about to change. Let me know why it is changing. I'm going to be visiting a polyclinic or a private doctor. Let me try to understand how the system works. When I come to the hospital, let me know what to expect. Don't come and sit down and be spoon-fed or expect the nurse or the doctor, the dietitian, the pediatrician to come up with things to say, and then you leave not knowing. Ask questions, be ready to engage. Know that we are trying our best. Know sometimes our best may not seem like good enough, but know we are trying our best. And it will be great if you meet us halfway. Engage us. Be a little bit more trusting.
So we do advise ladies, be aware of your body. As you go to your antenatal care, they will tell you the things that you need to come to the hospital for. Things such as if you're experiencing abdominal pain. Yes, you may have pains throughout the pregnancy. The old people will say you do get those little aches and pains. But if you're experiencing, pains that, something simple as a Panadol cannot relieve, you need to come and be assessed and see what is happening. For sure, if you think that you've gone into labor, we do advise you, time your pains. If your pains are coming one every 5 minutes, one every 10 minutes, yes, you need, and consistent. I always say consistent. For an hour, you know that you need to come to be assessed to see if you've gone into labor. For sure, if your water has broken, that's the bag of water surrounding the baby. If that water breaks, whether it happens in a leak or a gush, or you're not sure if it has broken, you need to come to be assessed. If you're having a bleed, you also need to come to be assessed, and you always come through the accident and emergency department so that they can accompany you here to labor ward.
The unit recognizes the importance of total family care. Accordingly, they seek to incorporate both mother and father in the overall care of the child.
NICU, some people call it NICU. As I said, it stands for Neonatal Intensive Care Unit. So we basically cater to a wide category of newborn babies. And those babies can be newborn from within the Queen Elizabeth Hospital or from other deliveries on the island. So as I said, it caters to a wide category of ill babies. Some we may have like cardiac anomalies, physical anomalies. We cater to a high percentage of premature babies, and those are babies delivered before like 37 weeks of gestation. Normally a pregnancy will go to 40. So we can have severe prems, which can be like less than 28 weeks, and those can weigh as little as 2 pounds or less. Yes, sometimes we may just have some babies that may just need a little antibiotic, so they may stay like a week, but our stay is basically from a week to 3+ months. It is a team effort, so it is what we call it the pediatric team. So there are the midwives, there might be the obstetricians, NICU nurses. So should a baby require attention from us, first they will alert us. So what will we do? We prepare. We have various equipment. First, they will come to us from their portable incubator. We will normally weigh the baby, do what we call vital signs, temperature, pulse, respiration, blood pressure. And the weight is instrumental as for babies and children on the whole. We normally use the weight for the calculations of medications and the fluid requirements. So they are weighed, and we do the vitals, we transfer them to our incubator. Well, some may require cots or may not require incubators. Generally, the doctor and the nurse will assess. Doctors will normally write up the treatment that is required, and we, the nurses, will administer the treatment. Also, we are what we call patient and family centered. So we don't only look at the patient, so we also incorporate the parents. Most of the time is the parents or what family may be there, right? So they are also incorporated into the care. So we don't just look at baby, we also look at mommy and daddy. So we are patient and family-centered care.
Well, in our next episode, we shall continue to celebrate the good work of the neonatal intensive care unit here at our hospital. I'm Sherwood McCaskey. Thanks for your time.